we on camera? Oh. So it creates a qualifying life event for women who become pregnant so that they can have access to health insurance. Right now we do that in Medicaid, but we don't do it in the private health insurance market. And but having the baby itself is a qualifying life event. And so what we're really doing is shifting the onus of the cost for that child. As that child gets older, they're more likely to have problems from not having that quality of prenatal care ahead of time. So there's a cost issue associated with this, and obviously there's a health risk to that child, because we know, as you'll hear from testimony, I'm sure, that prenatal care is one of the ways that we ensure that children have healthy lives and overall decreasing costs in many different ways to the state. So this was, I got this idea from New York State just recently passed this. In Rhode Island, we have an incredibly great insurance amount of people insured who are pregnant. So we're actually talking about a very tiny sliver of the market. It's about, last year, Kids Count estimated that there were 99 women who were uninsured and delivered a baby. So we're talking about a very small group of people, but obviously for those individual women, it makes a great deal of difference to have access to the health insurance, and for those 99 babies, some of whom may have not survived birth because of lack of prenatal care, it's incredibly important to them as well.
The first witness we have is Nicole Aguiar, March of Dimes.
Thank you, Chairman Miller. Is this on appropriately? It is green. Okay. Thank you, Chairman Miller and members of the committee, for an opportunity to speak today. I'm Nicole Aguiar. I'm here on behalf of the March of Dimes here in Rhode Island. I submitted written testimony as well as a fact sheet, so I'll just keep my points brief. March of Dimes, as you may know, is committed to the health of moms and babies. We're very appreciative of Senator Golden introducing this bill that will do, as she said, increase access to prenatal care by making pregnancy a qualifying life event. So prenatal care can cost $20,000 for an uncomplicated baby. So as you can imagine, when pregnant women have to pay for this on their own, they're likely to forego or delay prenatal care. And babies born to mothers who do not receive prenatal care have an infant mortality rate 5 times that of women who receive the recommended amount of care, and are 3 times more likely to have a low birth rate baby. As Senator Golden mentioned, it does also make fiscal sense to invest in prenatal care. The medical cost of a preterm baby is around $55,000, whereas an uncomplicated or healthy baby is about $5,000. So qualifying life events right now, some include marital status, change in Medicare, Medicaid, and birth. And we think that given the importance of prenatal care, we strongly support adding pregnancy to this list of qualifying life events. Happy to answer any questions you might have about that.
Thank you. Jim Beasley.
Hi, members of the committee. My name is Jim Beasley. I'm a policy analyst at Rhode Island Kids Count, and we strongly support this bill. Before you, I submitted written testimony as well, but I'm just going to highlight some of the data that we've been tracking in our annual Rhode Island Kids Count fact book that shows the coverage gains that we've made as a result of the Affordable Care Act. So when you're looking at the census level data of the number of women ages 18 to 34 who have health insurance coverage, it increased from 83% in 2013 to 90% in 2014. So we are seeing more women of childbearing age get health insurance coverage. But there are gaps that still remain for pregnant women. As Senator Golden mentioned, there's about 682 births to women between 2010 and 2014 were to women without coverage, so that translates to about 1% of all births. The good news is, just like with the ACA coverage gains we've seen steady declines in the number of uninsured women giving birth. Between that time period of 2010 to 2014, the number of births declined to uninsured women by 39%. So we went from 162 births to 99. So we're looking at about 100 births right now a year that were uninsured that could potentially have gained coverage with this legislation. And so when we sort of track in our annual fact book, we always compare different demographics of maternal and child outcomes. And we did this with insurance and without insurance, and we looked at the factors of delayed prenatal care, low birth weight, preterm, and infant mortality rate. These are all explained on the bottom portion of my testimony. And you'll see that women without insurance are at increased risk for all of that. In some cases, they're double. In some cases, triple the rate of infant mortality or preterm or low birth weight. So clearly, insurance status has strong correlations to a child's outcome and the costs that are associated with that. So that's why we think this is a very important piece of legislation that would help close a small but critically important coverage gap for women who would qualify for commercial coverage. And we also believe that it would help increase access to prenatal care, which could result in improved positive health outcomes for both the mother and the child, as well as reduced health care spending. So the Rhode Island General Assembly, we know that you guys have shown strong support for ensuring access to health care for all people, including women and children. We think this is another important positive step in the right direction to ensuring that more women and children get access to the care and coverage that they need, and so we urge you to support this bill.
Any questions?
Thank you.
John Donahue.
Thank you, Mr. Chairman, members of the committee. To clarify a couple of misconceptions related to this legislation, pre-existing conditions have not been part of our mission since we were created 75 years ago. In fact, for the entire time of our existence, Blue Cross has been the insurer of last resort in this jurisdiction. We took all plumbers, no matter what their condition or their health status. That's part of our mandate through the legislation that created us. So the ACA, and part of the things that it brought to our society, is making that rule the law of the land. So now pre-existing conditions are eliminated from all insurance plans, not just Blue Cross Blue Shield of Rhode Island. We think that that is a positive. Other insurers should not be able to pick and choose and cherry pick members. What this legislation would do, however, is undermine the provisions of the ACA that require people to get coverage. One of the genius elements of the ACA is that it expands the responsibility for people to get coverage, and it subsidizes heavily, either free or heavily subsidized, up to $45,960 for individuals to get coverage. What this legislation would do is provide an opportunity for individuals to wait to see if they get pregnant and not buy the coverage they're bound to under the ACA. They would have an automatic right to purchase at any time of the year. We think that the unintended consequence of this legislation is actually to undermine that part of the ACA and actually increase the likelihood that the numbers of uninsured would increase, because if I had a right, or if there was a right to have an individual be insured as soon as they become pregnant, then there would be no incentive for them to pick it up during the open enrollment period. The only way insurance works is if you buy it when you don't need it, so it's there for you when you do. We do not allow for homeowners insurance to be purchased when the house is on fire. We do not allow auto insurance to be purchased after the auto has been in an accident. And health insurance only works if everyone is responsible and gets insurance before they need it. Blue Cross Blue Shield supports prenatal care. We support Kids Count. We support the March of Dimes. We even support a program called, and I'm not going to pronounce it properly, but Duala, where we pay for these people to assist in not only the prenatal care of the unborn, but also the questions that come up around newborns. And it's been a wildly popular program. We think it's the right level of care. And although this legislation is extremely well intended, we think the unintended consequences could undermine the very aspects of the ACA, because if a special enrollment period is granted for individuals with pregnancy, we think it will be only a short matter of time before you hear from people with cancer, ALS, diabetes, and all the other conditions that are certainly serious and encouraging people to get insurance. Last thing I'll say on this item is, in today's paper, New York Times, a proof needed to enroll in health plans post-deadline. The Obama administration is now making it very clear that the open enrollment time is when you should buy insurance, not in the off cycle, because they want to make sure that the coverage is there and in place. They put in the subsidies to make sure it's affordable, and they don't want these special enrollment periods used to undermine the basic tenet of Obamacare, which is everybody gets insurance. Happy to answer any questions.
Thank you, Sean. Those are interesting points. First of all, I want to point out in the analogy to buying insurance on your home when the fire is burning, we also don't require homeowners to pay $55,000 to have the firefighter come into the house to stop the house from burning. So we want to make sure we realize that that's actually an apples and oranges comparison. But more importantly, because we know that Medicaid already allows for this, given your argument, and I understand where you're going with this, if it has unintended consequences, have we ever learned that lesson from Medicaid? Do we think that having open enrollment for women who become pregnant and therefore can be covered by Medicaid has prevented them from getting health insurance prior to the moment that they become pregnant?
Senator, I would point out that the claim that is paid when the house burns down is paid for by everybody paying the premium along the way. So I'm not sure that the analogy isn't spot on. Regarding the Medicaid is an entitlement, and that's totally different from a commercial insurance product where you have to make it stand on its own 2 feet. The taxpayers aren't there subsidizing the Blue Cross Blue Shield to provide the insurance. We have to have enough premiums coming in to pay the claims going out. So Medicaid doesn't have that responsibility. So I don't think that analogy is right on the money for this analysis.
On that point, to follow up on that point, Medicaid does have a fiscal responsibility, though.
Yes.
And do you know if they have done analysis Medicaid is basically insurance for those who fall below a certain income level. And so there's more similar to a Blue Cross product than there is different as far as what it's meant to cover and how you follow through on it and who the providers are and who the conditions that are covered and how those conditions are covered. So I was wondering, with that in mind, if, following what Senator Golden suggested, has there been an analysis of savings versus expense, whether it's a good idea or a bad idea to wait till you're pregnant or close to pregnancy to Medicaid, that they are saving money versus what they expect not only from the mother but from the child as expenses by having that coverage?
I'm not aware of any such study, Senator.
Have you, as Blue Cross or any other insurers other than Medicaid, done any research on whether there is a savings versus an expense to cover close to pregnancy rather than?
I know for our members, we are very aggressive about informing them of the benefits that are available to them, including the Duala program and other programs where we make sure that they're aware of the services and benefits that are available to them during that period, because we support the idea of making sure that women and all people have insurance, and especially those that are in need of it. But if you wait till you need it to buy it, it won't be there for anybody.
But it still could be less of an expense to the whole insured group if people are accessing prenatal care.
Happy to query my actuaries on that and see if they have some data. But
at the same time, I would maybe further understand the issue if understanding your participation in the groups that you talked about is that there's also an issue that has gone on as long as there have been insurance, is you can have insurance, but do you access all the appropriate care?
Right.
And I would understand that you're involved in Kids Count and all the other organizations that encourage participation in prenatal care. It's because you know there is a dollar savings in that participation. And so there must be, maybe, maybe not, but I would lean towards the maybe, that there is savings towards enrolling somebody in insurance and therefore having access to the patient to get them familiar with and potentially enrolled in prenatal care.
Our fear is that individuals will take this authorization to wait until they become pregnant to avoid purchasing health insurance and avoiding the mandate that Obamacare included for everyone to have the responsibility to buy insurance.
Is that any more of or less of a concern than having people who are already insured with you not accessing the maximum amount of care to save and protect their pregnancy?
I would say that we are very aggressive about making sure our members know that there are an array of benefits available to them when they are pregnant and about to deliver, and even post-delivery. There's a nice article in the Providence Journal about an interaction with one of our douala just last week. And I think it's a program that's going to be around. Our members seem to like it.
Any other questions? Senator Golden?
I think the point that we're really trying to make here is that unlike any other thing that you've compared it to in terms of cancer, any other conditions that might occur, the act of having the baby makes it a qualifying event for health insurance. And so it would presumably, given the data that's been presented by March of Dimes and Kids Count and is known quite widely, that the quality of prenatal care and access to it means that there's going to be better health outcomes for that baby. There is presumably cost savings to you as an insurer along the way by absorbing some of that initial cost. Also, this doesn't remove the mandate. It just creates another opportunity for becoming insured.
I take your point, Senator, and as I mentioned to the chair, I'm happy to question our actuaries if they can determine the cost-benefit analysis that he described.
So, would you have a concern with this legislation if it instead can be enrolled? It says denied now, but can be enrolled. So an insurer could decide on their own whether it was a good idea to enroll somebody.
I don't know, Senator. I think the fundamental question is Obamacare works because everybody has to get insurance. Right. And this gives people an opportunity to wait to get that insurance. That's the fundamental flaw, and I'm not sure that that corrects that flaw.
I think we all agree that that's a good idea. And there might be, even though it's a bad idea to wait, it might still be a good idea to enroll somebody. And Blue Cross may decide that it's a good idea or a bad idea. Neighborhood might decide if it's a choice for the insurer to allow enrollment at the date of pregnancy. Their actuaries might decide that at any point it's a good idea to enroll that person based on the actuary of the health to the mother and the health to the child for potentially a lifetime that they decide to participate.
I certainly understand the quite admirable intent of this legislation. We all think prenatal care is quintessentially important to our society. But just to reiterate, CMS just ruled last week, and it's reported in the New York Times today, it's in your packages, that they will not allow pregnancy to be a qualifying event. So I don't know. We have a state-based exchange. We have not a federally facilitated model, which is where that would lie. But I know that they're looking into the New York statute to see if it complies with the intent of Obamacare as well. So I'd love to take that one back to legal minds that are better than mine.
Let's hold the bill until we take that back to legal minds. All those in favor? Any opposed? We will hear is Senator Archibald 2208.
Mr. Chairman, members of the committee, good afternoon. Thank you for hearing this bill. There are two before you, so let me just get the number right. 2208. So I put this bill in last year. What this bill essentially does is it requires the current law, which gives dentists 15 days notice to changes of the implementation of any plan, the same effect for consumers or for providers to consumers, so that an employer or a patient gets the same courtesy as the dentist before a change in the plan is made. The Health Insurance Commission has sent me some paperwork on this today, and I know they support the bill. Last year there was an issue with cost. I don't know what's been followed up with respect to that. This is a very good consumer bill. It promotes transparency. It's something that should have an even playing field across the board. There's a fundamental fairness in the spirit of this bill. So other than the associated costs which were raised last year, I don't know what type of blowback there'd be to implementing this consumer bill. I'm open to any questions on it, but I think this is a sound bill, and I'd ask that it be moved out of committee.
Any questions? Thank you. I think we will hear from the Office of the Health Insurance Commissioner on this, but I think I'm not sure they stated a position in favor of it, but they submitted a letter to just give us some data on what the bill would
They seem
enable.
to support this bill as opposed to the next bill where they've taken a sort of a neutral position.
Okay.
I'm being kind.
Yeah. Any questions for the Senator? Thank you. Patrick Quinlan from the Dental Association.
Good afternoon, Mr. Chairman, Senators. The Dental Association supports this bill, and we thank the sponsors for putting it in. If you remember back in 2008, you passed a bill, and I brought the same props I brought then in 2008. These are utilization review guidelines. These are the criteria that the provider must meet in order to be paid. And during one 24-month period, they had issued 10 binders of changes, and nobody was told about it. The dentist didn't know about it. Nobody knew about it. So you, I think, justly enacted a law that you had to provide the dentist with notice at least 15 days prior to the implementation. But the problem is that utilization review changes occur during the policy period, and now the dentist may get a notice about it, but the patient has no idea that it's happened, and the payer, being the employer typically, has no idea that this is happening. And so what happens, the patient comes into the dentist's office, and they've pre-planned a procedure. Something changes in the utilization review guidelines. The patient comes in, and the dentist has to tell them, well, that's no longer covered because you don't meet the criteria. The criteria changed since your last appointment. And in order to perform the procedure, the dental plan is not going to reimburse the dentist, so you're going to have to pay for the procedure. So they turn their rage on the dentist and say, well, look, you're just trying to basically take money out of my pocket. So the Health Insurance Commissioner in her letter did say that we support the notion that patients and providers should be aware of changes to their plans and their coverage. And these are guidelines, and guidelines are clearly covered in the existing law as well as the proposed extension of the law to payers and patients. So we think it's a fairness issue that patients have an opportunity to make a sound decision prior to the time that they arrive at the dentist's office and pick a procedure and know that they've met the existing guidelines. So I'd be happy to answer any questions. Thank you, Chair.
Mike Ryan, representing Delta Dental.
Thank you, Chairman. Mike Ryan on behalf of Delta Dental. We respectfully are in opposition to the legislation. It's certainly well intended. We support transparency. We've submitted written testimony. There is a wide regimen of statutes and regulations which require a number of consumer disclosures, in terms of any benefit changes, we absolutely have to notify individuals of any changes in their plans that either they have made or their employers have made on their behalf. What this legislation does, and we've attached to our written testimony the policies and procedure changes that the current law requires us to provide to dentists. So I would encourage you to look at that. They're overwhelmingly highly technical disclosures on changes in billing codes, professional practice guidelines. They really wouldn't have a tremendous amount of meaning to the average individual subscriber. So that's our primary concern with the legislation, is that it wouldn't mean a lot to individual members. The legislation, we think, is duplicative of some existing disclosures that we're required to give to individuals. And our last objection is the bill as written only applies to nonprofit dental service corporations, so it only applies to Delta Dental in its current form. So we object to that as well. I think we talked to Senator Archambault last year about that. So we would just ask that if you're going to move forward with this, that it apply to everybody in the market equally. I'd be happy to take any questions.
Any questions? Senator Hughes?
Yeah, is there any particular reason why you believe that this legislation is only applying to your particular company?
Because we're licensed under 27-20.1 is the chapter of the general laws that we're licensed under.
Yeah.
So Blue Cross, Met, Guardian, other insurers are licensed under other chapters of the general laws. So as it's written, it's only amending that statute. So that's the.
And you think this requirement of reporting changes is burdensome? Is expensive?
There would be costs to it, certainly, but I think the primary issue is what's the value to the consumer given what we provided you. It's very technical. Providers certainly need to know any of those changes, but I don't think the average consumer is going to understand what a change to the maxillary anterior, cantilever, bridges, listing, cuspids as an abutment. I don't think they would understand that. So,
Jim,
let's get to your two parts of the bill that you have an issue with. One is that doesn't apply to everybody. So if it was redrafted so it applied to everybody, that would diminish your concern with the bill.
On that point, yes.
On that point. Second, on notice of any changes. Is there a way for Delta Dental, or if it applied to everybody, anybody who provided insurance for dental care, to delineate, or could you do it through language in a legislation that said any procedure that had an economic impact on the consumer, that the legislation would require disclosure of those changes?
So if there was a change in the out-of-pocket impact to the consumer?
Yes.
My understanding would be that would be covered in other areas of the general laws. Any benefit changes in terms of percentage of coverage or co-pays, co-insurance. My understanding would be that would already be required to be disclosed to the consumer in other sections of the general laws.
So would that require a change in the statute to clarify that?
Pat referenced UR, utilization review issues. This bill doesn't amend the UR statute, so if to the extent there are UR issues, we're happy to talk to them. I think OHIC has pretty broad authority to require us to change the way we're notifying those types of disclosures. But to the extent that there are UR, utilization review issues, I'm not sure that this bill touches those. But
Senator Chief.
Yeah, one of the previous witnesses had demonstrated there were a number of new binders that were sent out for notifications and changes of what would be covered, et cetera. Do you agree, is that accurate?
It was accurate in 2008 before the current law that you're looking at. So the language on page the existing language on page 1 of the bill, that instance was the impetus for you passing this legislation requiring disclosure to dentists, and that's what we provided was this year's version of what those changes were. And again, it's highly technical. It's not readily understandable by the, but it is also available on our website to anyone. That's how I got it. I pulled it off the website, so it's out there. But I don't see consumers clamoring for this.
Was that an anomaly that took place at having so many, or are there normally in the course of a year a number of changes that would amount to 2, 3, 4 or more of those binders per year?
So there were a couple issues with the impetus for the existing law. I think that the reference that Pat brought up, I think that was an anomaly. I think there were more changes than usual. I wasn't working on the issue at that point, but I can go back and try to find that out. But the other issue was there wasn't a requirement to have those changes redlined, and that's what the existing law does, is that you can't just send us a binder with the new policies without redlining it. So that's the existing law, the disclosure.
So that the changes incorporated in the existing previous, things that you have, coverage or whatever.
Yeah, that's my understanding, yeah.
Okay. So you wouldn't describe it as being numerous changes in a year, but fewer changes, but every time you made a change, you had to send an entirely complete section of changes, the changes with what was previously there.
To the dentist?
Yes.
Yes. So
okay.
Prior to the existing law that you're looking at, the dentist objected to having a new binder without knowing specifically what the red line changes were. You passed legislation to require that. We're complying with that. Yep. We're just saying that sending that disclosure, which goes to a dentist, which is very valuable for a dentist to have, we just don't think that every individual member would find value in those particular disclosures. Again, lots of other information is sent around benefit changes, plan design, and other sections of the law to individual members in a way that's readable and understandable, but you can't make billing codes. It is what it is. It's very highly technical. So that's our concern.
Thank you, Mr. Chairman. Thank you.
Any other questions? Thanks. Tara Coffin-South from the Office of the Health Committee.
Good evening, Chairman and members of the committee. If I could just address Senator Archambault real quickly. Last year was my first legislative session, and it was really helpful to understand the direction and the intent of the bill. So coming into it, I didn't get the full picture of what you were looking at. And after you go back and reevaluate, it is more helpful to analyze these bills a little bit differently. So that was my fault. I should have reached out to you beforehand. So I apologize for that. So now I have a better understanding of what you're really trying to get to. As far as what Pat brought up about UR, I can't really talk on that issue, but what I can talk about is what goes on in our office. And like Mike also said, or Pat, maybe he quoted me, that we do believe that there needs to be transparency. Everybody needs notifications on changes. That's important. We don't deny that. I just want to walk you through that what goes on in our office. So the dental plans that are filed with OHIC, the enrollee's coverage can't materially change once it's presented in the certificate of coverage or the schedule of benefits during that enrollment year. Now, subsequent plan years would require approval of any material changes through our office through the form and rate filing. Now, with that being said, we are open to maybe talking about how we can have this bill work with our form and rate filing and maybe addressing some of the notification requirements through the form filing, to have the carriers provide certain types of notification, maybe even more readable notification to the providers and patients.
Tara, just for our
Yep.
understanding, form file is what goes out between the term dates?
What do you mean between the
enrollment and
Enrollment, so in order for them to, before enrollment goes out, the forms have to come into us.
Right.
And their rates. And we have to approve them before they can send anything out
Right.
to, for patients to sign on to.
But what Pat Quinlan presented to it was a binder of changes that went out between enrollment and expiration.
Right. Those are, the UR stuff
Right.
doesn't pass through us. So if there are changes that are made on that end, I can't talk to what might need to be cleaned up in how that process is done. But I think that one thing we could take away is that there are mechanisms already in place, and maybe we need to clean up on a regulatory area.
So would one approach be that we would put further language in that UR process that says you cannot do a UR process between enrollment period that without notifying the consumer if that UR process creates an expense for the consumer?
It could be that way, or we could take a look at the UR bill, or UR law, see where there is language where there may be an area to write a regulation to be very specific. Because you can get more specific in the regulations.
Right.
So that might be an area to address that. And again, too, we would be willing to figure out if there's something on the form side when we're sending out the instructions that we can add.
So if there was an interest in going both through a legislative procedure of a bill that addressed this, while you were examining whether there was a regulatory way to do this, would you be interested in the Health Insurance Commissioner's office in recommending language that protected consumer from changes in UR during that enrollment period?
I don't know if that falls in my jurisdiction.
Okay.
So I don't, that I wouldn't know. Okay. I don't want to put anything out there that I can't take back.
But if the sponsor or our policy or legal office tried to do that by amending the bill, you would look at it and comment on it, right?
I would look at it and I would comment on it, yes.
Any other questions? Thank you.
Thank you.
So we will make some tries at that and hold the bill until we do. Is there a motion to hold? Seconded by Senator Satchel. All those in favor? Any opposed? Thank you. Senator Archibald can revisit us for Senate Bill 2462, Act related to insurance surprise bills for medical services.
Thank you, Mr. Chairman. Before I move to that bill, I just want to touch on a couple of quick points. First and foremost, thank you, Commissioner, for coming up and for talking on the bill. I will tell you that 6-7 years ago, when I ran for Attorneys General, I met with Commissioner Kohler, and I spent a lot of time reviewing the Health Commissioner's office, and at the time I found you to be underfunded, and I thought you needed more money and more resources. So there's an inherent bias in my legislation here. I favor the consumer above all. So we talk for just a split second about the notice requirement. As I'm sitting listening to Mr. Ryan, I'm thinking, wait a minute, I get my electric bill, right? I don't understand my electric bill. Maybe Billy Walaska does, maybe Senator Walaska does, but I certainly don't understand my electric bill, but I still get it, right? And the burden's on me to go through it and understand the minutia. This is about notice and fundamental fairness. The same thing holds for my cell phone bill. If any of you understand your cell phone bill, well, you're better than me, because I usually have to ask my wife. I don't have a clue, and it takes me some time attorney. I'm not an engineer. So, and I think you need an engineering mind to understand half of the minutia that's in these bills. With that said, it's about notice and fundamental fairness. And I want to be kind here, but to take a position that says that because the consumer may not understand the details and minutia in the bill, we shouldn't provide it. That's a faulty syllogism. That's illogical. It doesn't make any sense. And I'm being kind to Mr. Ryan. It frustrates me. That's not a sound position. I discard that offhand. This is about the consumer. This is about giving the consumer what they need, which is notice in the changes in the law. It's that simple. That simple. With respect to making this broad for all dental providers, I agree. I think that's a great stretch. Let's expand it. And Senator Miller, Mr. Chairman, you summed it up. You're right on the money with that, and I think it should be fundamentally fair, and I appreciate Mr. Ryan addressing that point. But I haven't heard a sound objection to this bill. Anyways, let's move on to the second bill that's before you, which is 2462. This bill, before I get into what the bill says, it's basically in its spirit a bill that addresses surprise health care changes. There's a piece that was just written yesterday in the National Law Review with respect to President Obama's insertion of changes into the budget for Health and Human Services for his 2017 budget. I'm just going to touch on a couple of parts of it because I think it'll help everybody to understand this a little bit better if you don't already. It says essentially that in the budget, the President's proposed provisions that seek to eliminate surprise out-of-network health care charges for privately insured patients. It's described as an attempt to promote transparency on price and cost and billing for consumers. And this measure will require hospitals and physicians to collaborate so that patients receiving treatment at in-network facilities don't face unexpected charges with respect to out-of-network practitioners. Could have far-reaching effects, they say, and those far-reaching effects are cloaked in fundamental fairness. They define a surprise bill very briefly. Surprise bill situation arises when patients incur unexpected out-of-network charges when receiving health care services at an in-network or participating hospital. And to give examples, here's a quick example. You may go to a certain physician, an anesthesiologist, or an emergency room will provide services to you as a patient and have an episode of care where there's a participating health plan, and then you're in a non-participating health plan. Even if the other providers who see the patient in the hospital itself are participating. Think about that. You go, and the plans you go to are participating, but that doctor is non-participating. Now who's responsible for the bill? The consumer's responsible for the bill. And the chase is on. That's not fair. That's not reasonable. That's not an appropriate dispute resolution. Other states are implementing this law right now. Texas, Florida, Illinois, Chicago, Maryland, West Virginia, and New York. And I took the model for this bill from New York. New York's the most stringent. And essentially, in those states, they're saying that if somebody is in a non-participating program and you have a dispute resolution, it removes the consumer from that dispute. And it makes the dispute between the provider and the health insurance company. Why should it be the consumer who goes in thinking they're participating in the network and then gets services from a non-participating network who's struggling to survive in our economy that's still rebounding after the Great Recession, has to be the one that's in the middle getting bantered around? It's not fair. It's not right. This is a great consumer bill out of New York, and I was really encouraged to be able to put it in. So, in a nutshell, this bill is cloaked in fundamental fairness. And I think that it will provide a remedy to our consumers so that if there's a dispute, they don't wind up in the middle. Part of this bill, that's not addressed in here, and it would need, it's something that would happen as part of the New York law. There's an acronym on it, FAIR. It actually sets the standard for the rates that would apply if there were a dispute. New York's law is well thought out, and we'd be prudent, I think, to model our own health care dispute resolution on that, on the state of New York. We all know that, as an ancillary note, since Obamacare has been implemented, whether you're for it or not, there have been some hiccups. This is one of those provisions that would help the consumer, and anything that helps the consumer is good with me. And I think that the doctors, quite frankly, would like it as well, because then they know, you go to medical school, you kill yourself, you incur $500,000 in bills to get to become a doctor, and then you're out there trying to make your business run, like former Senator Ardiano, and you've got all this red tape you've got to go through. You don't need to be chasing a consumer on the bill. You should be going after the health care provider. Aren't the nonprofit health care providers here for the consumer? They're not here to be self-serving, and I'm not going to get off on a tangent. I'll save that in the future for another campaign. Anyways, I'm open to any questions you might have.
Any questions?
Just a comment. I'd like to compliment the sponsor here. It's obvious that you have a great passion for this issue and also for defending the consumer. So I salute you on that. Thanks,
Mr. Chairman. Appreciate that, Senator. Thank you very much.
First person signed up on this bill is Patrick Quinlan. Tara Provençal.
So we strongly agree that this is a huge issue. There's no doubt about it. But how to go about fixing this problem, I think that's where we don't know if this is the best way. This is beneficial. Dispute solution problem is great after it has happened, after you've received the surprise billing. But how do we prevent surprise billing from going out? And I think that's where we would want to start from the ground up. Going back to another law that we already have in place is the Health Plan Act, which is Section 23-17.13 of our laws already. It's not under my jurisdiction, but that law does ensure that there's access, quality of care, and continuity of care. It's very broad. It's an area where we can start to implement things like surprise billing and preventing it in that area. We're open to talking to the state agency that it falls under, working with the sponsor and other stakeholders that are interested in this, and figuring out how we can prevent surprise billing versus just having a solution after it happens. I mean, you know, we're fine if you want to have this process come through OHIC. We just think that we need to start from a different level and not make it happen. And that's what's really important to us. It's going to be complex. It's going to be difficult, especially when networks are getting narrower. But I think if we all come together and really figure out a way to do this, it needs to happen. And other states are moving in different directions to prevent this, and we should be on the map for that.
Senator Sheehan.
Thank you, Mr. Chairman. Is your office empowered to actually apply some preventative medicine in this situation?
Apply what?
Some preventative medicine in this situation.
We can. We can. There's ways that we could do it. We can work with other agencies as well. We can. We're limited, but I think if we, like I said, if we come together with other agencies, we can definitely, especially with health and using that Health Plan Act, we can really focus on some things that we could all do together to regulate.
So just to,
but as far as like this process,
yeah,
whatever you give us, yeah, we can. If you want us to do it, we'll do it.
So in the preventative vein, you would say you'd have to collaborate across various departments to try to coordinate and work this through.
And I think it would take other people too, other stakeholders too, to figure out, especially understanding from the carriers their networks and how they're going to work and how we can kind of hone in on where we put the pressure.
Yeah, because what that says to me, and I could be totally wrong, but that maybe there needs to be some clear mandate to be able to do this, and then the rest would fall into place easier on the preventative side.
Right.
Is that a fair statement, you think?
We don't want any mandates out there.
A mandate in terms of providing in statute, yeah, as opposed to you
to have people work together to
yes.
go. Yeah, I mean, we could do that, or we. I know this is an area our office does want to look at and will look at, so whether it's in the law or not. This is on our agenda to take a look at. So
this year's agenda, or?
Yeah, we're constantly trying to catch up with the way healthcare is evolving, and this has been a huge issue, and it shouldn't be an issue for our state. We should try to get ahead of it. So it is on our agenda to look at.
All right, thank you, Mr. Chairman.
So would it be fair to say that most of the occurrences of this surprise billing, as it's called in this legislation, are in a procedure, there's a practitioner that is out of network and therefore incurs either an uninsured expense or an expense with a higher copay because it's out of network? Would that cover most of the incidents that this kind of legislation.
Yeah, and I think, too, we want to understand if there is particular practices, which I think we can all guess, like anesthesiologist, usually that's the case. You're in the hospital, you're ready to go under, and they'll come in and be like, I'm not in your network, and here you go.
Right. So would it be also fair to say that one way to solve it is to say there's a notification requirement that the hospital has decided, or whoever's providing the services, because it could be in a surgical center also or something.
There's ways to either provide.
So the solution may be, if it's not accurate to this legislation, it could be amended where potentially that the provider of the services took the risk if there wasn't proper notice to the consumer and or the payer.
Right.
And
right. I mean, that's definitely something.
If the legislation doesn't effort that, there's a way to solve it, probably through that notification. Guess what? If you didn't tell them, you're paying as if they were in network.
Right.
If you did tell them, you got to prove you told them and they signed off somewhere.
Right.
Either or both the consumer and the payer.
Right. I mean, I think notification is a huge part of this. Yeah.
Yeah. Okay. Next is Mike Cronin, written testimony and support from the Health and Human Services. Patrick Quinlan.
Thank you, Mr. Chairman. Sorry, I had to take the call outside. We support this. We're not sure on the language yet, and certainly we think there has to be a dispute resolution provision to make sense for a quick resolution. But we haven't had a chance to get feedback from all of our clients on this, so I'll submit a letter once I clarify I have one client I haven't reached on it. So, but the concept of notice and everything else we agree with, but just how it's going to work and how a dispute resolution mechanism could be implemented is the piece we want to discuss with the client. Okay. Thank you.
It doesn't just address surprise. I would concur with Tara Provençal from the Office of the Health Insurance Commissioner that this is a growing problem. Fortunately for us, most doctors and providers are participating with Blue Cross because of the market share that we enjoy. So it is not generally an issue. And when it does come up, our general practice is to hold the member harmless and to negotiate with the provider. But as a non-participating provider, they can charge anything. They have some requirements under their licensing and their professional ethics, but they're not bound by our fee schedule for sure. So we think, as OHIC pointed out, that this should be avoided rather than getting to the litigation or the mediation or arbitration phase. We think it should be avoided ahead of time. And in October of 2015, the National Association of Insurance Commissioners released a model act, which we feel is the appropriate way to approach this. And I'll just read one sentence because I think it does exactly what you just suggested. When a participating facility schedules a procedure or seeks prior authorization from a carrier for non-emergency services to a covered person, the facility will provide the covered person with an out-of-network service written disclosure. So we think that that is the approach to help prevent this issue from arising. And I'm happy to present your counsel with the research that we have regarding the NIAC Model Act, the National Association of Insurance Commissioners Model Act. We think that approach is a more appropriate way to address this issue.
So would it be accurate, I mean, you don't have to, that most of these incidents on our Blue Cross incident, because Blue Cross has built a network over a long period of time that prevents these kind of surprise billings to usually happen.
Generally speaking,
insured by Blue Cross.
I had a family member that got a weird,
I don't want to advertise for Blue Cross, but
appreciate it.
Yeah.
But we had a family member that got a weird billing from an out-of-state laboratory with an outrageous fee, and it was a non-participating lab where this culture was sent, unbeknownst to him by his provider. So it does happen, and it was in a California laboratory. So I can't say we're immune from it.
Right.
And it should be addressed because certainly we don't want a practice that incentivizes people for not participating. We want members to understand that they're getting a service for a fee that is reasonable and that is quantifiable.
Any other questions? Thank you.
Thank you.
So all I say that we're forming our membership now on this particular issue, and I'll let you advise the committee of the results of that. But I think generally speaking, if they're in favor of some resolution in the direction of the legislation we're talking about, and as Sean mentioned, the NAIC model. I believe there's got to be a resolution so we prevent these surprise billings.
Any questions? Thank you. Steve DeToy.
Thank you, Mr. Chairman. Steve DeToy with the Medical Society. We also are in the position of polling some of our members, and we have one of our specialties here this evening that's going to give you their opinion on that. I wish it was as easy as saying we can prevent this, but as we continue to evolve in the healthcare system, and Mr. Donahue pointed out that at this point, and historically, most physicians are in the Blue Cross network. But it's foreseeable that Blue Cross decides that they're going to lower their rate or they're going to offer a limited network, and not every physician will be able to join every network that Blue Cross, and you were giving them an infomercial, and I'm kind of trying to balance you off now. So I could pick United, but they're not here, so that wouldn't have the impact. But as we get into limited networks, and this will dovetails into the next bill you're going to hear from Senator Satchel, I think it's important that there's a mechanism. So it's easy to say we hold the patient harmless. We all agree on that. But you can't favor one side versus the other, and Senator Archambault, I think, is left. But that language that's in the New York statute seems to be a decent balancing act. I can't endorse it tonight, but I don't. I wish we could keep it from happening, but I think as our system continues to evolve, it's going to continue to happen, hopefully at a lower rate, particularly since we're selling very high deductible plans. Patients have higher, that price could be a little higher than it might have been otherwise. So at this point, I'm going to have to get back to you on a medical society position, but Dr. Cirillo is here for the emergency physicians. Thank you, Mr. Chairman.
Well, the higher networks, the higher deductibles sometimes are a limited network of providers, so
it could be happening more and more.
So it could be happening more and more.
And those limited networks often, I can't say often, may sometimes come with certain conditions that a participating provider and other Blue Cross plans may not want to participate in. And so if a patient finds themselves and most of this is institutional based, but it does happen in the community, and that's getting ahead of myself on Senator Satchel's bill. There just needs to be a resolution. Hopefully it doesn't. We can reduce the frequency it happens, but I don't think we can totally eliminate it.
But with limited networks, you could be in a situation where you
could have more
identified that you live in Providence and that you have a network that covers Providence well, but you got hurt in Westerly and may not.
Yes.
A network
and again, that would probably be in an institutional setting, but it is conceivable that you are referred to a specialist and you go there thinking they may be in network, and this getting ahead of myself here. And you find out when you're there, or you're already there, that they're not in network, and they may not have known it when the referral was set up. So that's what I'm saying. I don't see it. Preventive medicine always best, but we can't prevent everything from happening. So we may need to have a dispute resolution mechanism that Senator Archambault is talking about.
Any questions? Thank you.
Thank you.
Cecilia Pelkey from the Hospital Association also signed on. in support but is not speaking and provided written testimony. So at this point, there are no other oh, you are here.
No, I signed.
Okay.
Testimony for this. I signed with a meaningful.
Oh, meaningful access.
Yes.
Well, it was the same list.
Did I sign the wrong one?
No, you signed them on the right one. Okay. It's exactly the same list except for your name and one other, so. Okay. Is it some? Now I'm confused. Oh. Dr. Cerullo, sorry. Yeah, I know.
Thank you, Mr. Chairman, members of the committee. My name is Dr. Anthony Cerullo. I'm here on behalf of the Rhode Island chapter of the American College of Emergency Physicians. So we're the ER docs in the state.
Yep.
The other hat that I wear is I actually, for ACEP on a national level, I'm the chair of the Federal Government Affairs Committee for the college. So this issue of surprise bills, balance bills, out-of-network billing is something that we've been addressing as a college, as a specialty, for a number of years. I will give kudos to the author and the co-sponsors of the bill. We've been watching this issue in many states, including New York and Connecticut. And the bill that's before you actually is a blend of a very good, what we think is a very thorough and vigorous dispute resolution process that was identified in New York, and then a fair way to develop a payment system in those situations where there is an out-of-network provider. As emergency physicians, when you come to see me, you may not have had a choice. You probably didn't. So in those situations where there's an acute illness or injury, you're going to go to the nearest emergency department. You have no way of knowing whether we are network providers or not. And my friend Sean Donahue, with his mention about market share, he didn't mention the flip side of market share, which is it makes it hard as an individual provider to negotiate with a very large payer who controls a considerable aspect of the market. So you will always have some providers who will be out of network for different insurers, and that changes on an ongoing basis. And so for a patient, for a consumer, there's no way to know if you're going to be with all network providers all the time. I think in those situations where it is a scheduled surgery or a scheduled procedure, I think notification to the patient is certainly the right thing to do. If you're in a motor vehicle crash and you're significantly injured, you're going to be cared for by emergency physicians, you're going to be cared for by surgeons, by anesthesiologists, by critical care physicians. There will be a host of people who will take care of you. There will be no way to know ahead of time who's in network or out of network. So creating a mechanism for that patient, for that consumer to say, look, we understand that in today's world with the insurance products that are sold with very high deductibles, where the deductibles are doubled if you go out of network, $6,000 or $12,000 out of pocket is not a fair cost to the average consumer. We understand that. Our goal here is to try and ensure that there's something that's fair to everybody. The patient, the consumer, should not be the person who gets left with the bill when there's been an inability between an insurer and a provider to come to some pre-agreement about what we get paid. The statute, the Connecticut statute that I think is also part of the New York language, talks about the greatest of three, and there's a mechanism by which the provider would get one of three payments, either the Medicare rate, which I'm sure is never the greatest of anything, the pre-approved or pre-agreed upon rate with an insurer, or a rate that's the 80th percentile of the charges that have been submitted for that region, for that code, for that specialty. So in this situation, there is a mechanism, there is an entity out there called Fair Health that now is collecting data in a geographic area based upon a provider's specialty for a certain code. And that data is then compiled and can be provided to OHIC. And that would be a mechanism to say, look, if you can't agree, then it's going to be the 80th percentile of charges, a median of charges. And in Connecticut, we all said that's very fair. It's not perfect for anybody, but that's fair. So I, again, would, from the emergency physician perspective, applaud this. I think it addresses an issue that's not fair to consumers and patients to put them in that situation. I think it has a good dispute resolution process and a fair payment component. So we're very supportive of the bill.
Any questions? Thank you.
Thank you.
Now we're through with witnesses on this bill. A motion to hold? Seconded by Senator Sheehan. All those in favor? Aye. Any opposed? So the last bill to be considered tonight is Senator Satchel's 2465.
Provides meaningful access to accurate provider directories, requires that insurers maintain accurate and up-to-date directories of all in-network providers, and that information is provided to all plan enrollees.
Any questions of Senator Satchel? The first person on this bill is Patrick Quinlan.
Chairman, to be brief, on behalf of the Society of Radiologists and the anesthesiologists, as well as the oral surgeons and dentists, we support this bill. We've supported it in past years, and we hope we finally get something out there that makes a usable-friendly or user-friendly provider database that a consumer can check, particularly when pre-arranging medical appointments. So we think it's a great bill. We thank Senator Satchel for putting it in and his co-sponsors, and we will support it in any way we can.
Any questions? Thank you. Okay. Mike Cronin, on behalf of EOHHS, submitted written testimony in support of the bill. Tara Provençal.
So along with what EOHHS has also submitted as a testimony, we too agree that we need to work in a way of getting a statewide provider directory that is extremely accurate. This is a very complex thing to do, very difficult thing to do. Right now, there is the statewide efforts going on between multiple state agencies and the Rhode Island Quality Institute. But we are working with RIMS and also sitting down as all the agencies come together to coordinate what this bill does and what is being done already, and try to make sure that we're mirroring what needs to be done and what is to provide an accurate directory. Very complicated to do, very scientific, and I don't get it, so don't ask me anything too scientific about the process. But we are working towards achieving some of the points that are brought in this bill.
Any questions? Thank you. Terry Martesian.
Chairman, members of the committee, Terry Martesian, representing America's Health Insurance Plans. And we generally obviously support the concept. Obviously, it's required to provide certain information in directories. It's a complex issue. This bill goes a little bit further than we can agree with, and that's the reason why I signed up in opposition to it. For example, we have no control over the hours of a physician's office. We just don't. We can't control whether or not a physician has relocated and gone into some kind of a, provider association. For this to work, and this is one of the biggest problems, is trying to get information, timely information from the providers themselves. And without that information and commitment to provide that information on a timely basis, it puts us in a bad position the way this bill is drafted, because it puts the burden on us to get that information. Well, they know what their hours are. When they change their hours, that should be their responsibility to their patients. And that's some of the reasons why we have a concern. We also have concern because, we don't know if a physician or a provider, let's use a provider, is stopped accepting new patients. You hear that once in a while. I'm no longer taking Dr. So-and-so or physical therapist is no longer taking new patients. We don't know that. And this is why, we feel, obviously, that we should sit down and try and work something out to get a meaningful bill for passage. The other problem we have is that the burden seems to be all on the insurance plans, the penalty provisions. And if you're going to have an effective directory, provided directory, then the burden should fall on both. And if it's going to be a burden on the insurers and they're going to be penalized and there's enforcement procedures, it should be the same for the providers because they have a co-equal responsibility to provide the information to us. Maybe more so in some cases. Because from them, we make the changes. We can't do it on our own. It comes from them in most cases. And that's the reasons why we feel that this bill, as presently drafted, is of major concern to us. And we feel that, again, we feel we can sit down, try and work something out. Something should be resolved. Obviously, it's required by the feds in many cases, although this one, like I said, goes beyond. And when I talked about that, about doctor's hours, the feds don't require that. About, patient notification. That's not from us. So we feel that we are willing to sit down at the table and try and resolve this in a meaningful way so it's good for everybody, especially for the consumer. But it's going to be a joint effort. Happy to answer any questions.
Any questions? I haven't looked. To your point about office hours or new patients, I see where it requires physician information, but I don't see where it requires hours.
I believe there's a whole set of criteria, and in it, it's about, on page 4.
Yeah.
The hours that the physician is available to treat.
Oh, hours the physician is available. Okay.
Yeah.
So if
That's
you
it.
took the
So
E out.
that's us, E. Right. That's got to come from the providers themselves.
Yeah.
And we have sometimes, we all have a responsibility here.
Because they do have physicians' website where they could access hours as supplies.
But if they change their hours, Chairman.
No, that's what I'm saying. If we eliminate E, but we still maintain the physician's
Well,
website.
there's still this goes far beyond what's required under the feds, as far as even the hospitals and there's information about payments, because there's some.
So the main concerns that you pointed out as concerns was accepting new patients in office hours.
I use that those are two. There's
It's
more.
examples,
There's
right.
much more.
Right.
I can put
But
that into writing for you, but
Before
there
the
are other
legislation,
factors.
we go further, we would show you versions of the legislation that were less specific, maybe.
We have concerns with this as presently drafted. Okay. I summarized and I highlighted, there's always and the other part about it, about the geographic, I think OHIC already has enough ammunition to make sure that our networks are adequate throughout the state. This legislature, I think, has given them that authority, and even under the federal, they have to be compliant, and it has to be an adequate network. So to put that burden also, it's, they're asking, it should be co-equal. We should all be there doing the same, doing what's right for the consumer. And this bill, as presently drafted, is slanted, putting the burden on the insurance carriers of the state. That's what I'm getting. Thank you.
Thank you. Sean Donahue?
Thank you, Mr. Chairman. In your materials, you can find two colorful pages which kind of give you a snapshot of how our doc finder or provider finder works right now. It's a utility that we've really spent a lot of time and money developing, and we think we'll have an app for this by the end of the year. In fact, maybe even in 6 months, because we know that this is going the way of the dodo bird. This is going the way of your phone book. It's not going to be an efficient way to communicate information, and the day after it's printed, it's obsolete. So we feel that the approach is to provide information in a more robust manner, in a more timely manner, and in a more useful manner to our members, so they can decide which provider to go to based on geography, specialty, what plans that they accept, what plans they don't accept, what education they may have. All of that information is something that they possess and they have to transmit to us. But the way the legislation is written now, it makes the plans legally responsible for that data. when we don't have it until they give it to us. So I think that's a fundamental flaw in the way the bill is currently drafted, and that's principally our objection at this point. Also, the other thing I wanted to bring to your attention is yesterday I was at the Rhode Island Quality Institute, and they are doing incredible work in this very area. They're putting together a provider directory that encompasses not just the health plans, but all of the delivery system mechanisms. They've invested a ton of money and effort into that. It's a project that I think they plan to have, according to their own timeline, up and running by June of this year. So I'm going to submit that to your council. I didn't make many copies of it because it's a rather lengthy PowerPoint, but many of the issues that seem to be an issue in the provider community, I think will be addressed by this tool that is going to be, Current Care right now receives 308 data feeds from plans, from pharmacies, from providers, from hospitals, from MRI companies. They send it all through Current Care, and Current Care distributes it and verifies it, validates it, and then provides this directory system in a way that it is useful to Rhode Islanders when they're trying to make healthcare decisions and healthcare services. It's deciding which healthcare services are right for them. So I'm going to submit that as part of my testimony, and I'd be happy to answer any questions.
Any questions? Thank you. Steve DeToy from the Medical Society.
Thank you, Mr. Chairman. I'm still reeling from having the Association of Health Plans agree with something we were doing, but then I was relieved when they went ahead and disagreed with everything that's in the bill. And I want to commend Blue Cross. Obviously, some plans do this type of customer service better than others. But before I get into that, and I want to thank Senator Satchel for enduring us again this year on this bill. Last year, you will recall, there was a lot of conflicting testimony about this and that and who's doing this. We seem to have gotten to the bottom of that, and Sean's just mentioned it. The Quality Institute has a contract with the state through the state innovation model to create a provider network. That provider network is based on whatever the health plans send them. We know, and we don't have to go very far back, the end of 2013 when United Healthcare decided to make some major changes to their networks that they didn't even know who was in their network. You can pick up information. So plans are selling plans. Insurers sell plans to consumers. Consumers have a right to know who's in that plan. And a lot of this data, and I take Terry's point very seriously because most of it's collected when a physician is credentialed. And there is I wouldn't call it co-equal, but there is a responsibility on the patient or on the physician to send that up. But I think we're going to sit down with the various state agencies because we want to support the Quality Institute's efforts, but it's one of those issues where garbage in, garbage out. And if there's not a requirement, and there isn't that I've found yet, unless Tara says maybe there is, but that requires the information from the plans to be as updated and as comprehensive as possible. So this bill you see in front of you that Terry was commenting on was kind of a placeholder to get this discussion going. The key issue is that in order for the Quality Institute's program to work properly, there has to be some kind of requirement that the information that's provided there for the $1.5 million or whatever it is that the SIM is spending is the best information possible. And I will accept Mr. Martesian's friendly suggestion that there is some requirement on the physicians community and the rest of the provider community to provide some of that data. We just haven't figured out how that's going to work yet. So,
would a potential solution be to have certain criteria for written directory and then changes available electronically as we're going through?
I'm going to say that the dodo bird analogy is probably correct, that we're not going to have anything that's printed.
Right.
going forward. It's going to
We
be
still do, and we
electronic
still have
based.
people that don't access electronically.
Understood, but
In the meantime,
we
need something in between.
Well, yes, and we need an ability to keep it current.
Right.
It shouldn't be a once-a-year snapshot, maybe 6 months, 3 months, whatever is reasonably doable
Yeah.
to keep that information as fresh as possible and as accurate as possible.
Yeah.
So that, we owe that to the consumers. The plans owe that to their customers. And if I want to get paid as a physician for services rendered and be on the Blue Cross panel, then I kind of have a responsibility to tell Blue Cross where and how I am. How that's put together in the Quality Institute's project that they're under contract with the state to provide is something that we have to learn more about before we figure out what information. But I think the concept that we all have a role to play for everyone's benefit is a valid argument or a valid point to be made.
Any questions? Thank you.
Thank you, Mr. Chairman.
So Cecilia Pelkey not speaking but in support, right? Oh, okay. No other witnesses on this bill, and this is our last bill. So we'll do a motion to hold for further study by Senator Coyne, seconded by Senator Sosnowski. All those in favor? Motion to adjourn.